Medical disclaimer. This video is produced for entertainment purposes only. I am a retired MD and PhD in biochemistry with specialization in orthopedic surgery, spine surgery, chronic pain management, and medical aesthetics. I am not currently practicing medicine, and nothing in this series constitutes medical advice, diagnosis, or treatment. All analysis presented is speculative, based solely on publicly available observations. No private medical records have been accessed or used. All individuals are presumed healthy unless proven otherwise by their own treating physicians. Viewer discretion is advised. Episode 5, The Hidden Treatment. Heavy dementia medications, frequent medical monitoring, and the evidence of concealment. In medicine, we are taught that the physical examination is a conversation the body has with the physician, whether the patient wants to have that conversation or not. Today, we look at the physical signs on this individual's hands, and we listen to what the body is saying. As I described in Episode 1, the recurring dorsal hand bruising, covered with what appears to be heavy cosmetic product, is a recognizable clinical sign of repeated IV access. The back of the hand is a standard venipuncture site. In elderly patients with fragile veins, and patients on anticoagulant therapy, bruising from IV access is inevitable. But here I want to go further than the cardiovascular explanation of Episode 1, because there is a specific category of IV medication that would necessitate frequent IV access. This category also matches the pattern of repeated cognitive assessments that multiple credible sources have reported occurring in private settings. In the last several years, the FDA has approved a revolutionary class of Alzheimer's disease therapeutics, the anti-amyloid monoclonal antibodies. These drugs, lecanemab, sold as Leqembi, and donanemab, sold as Kisunla, work by binding to and clearing amyloid plaques from the brain. They represent the first disease-modifying treatments for Alzheimer's, not symptom management, but actual plaque clearance. Their administration protocol is clinically demanding. Lecanemab is administered by intravenous infusion over approximately 1 hour every 2 weeks. Donanemab every 4 weeks. The infusions occur at intervals, in an IV suite, in a physician's office, or in a sufficiently equipped private setting. Both drugs require multiple MRI brain scans before and during treatment to monitor for a serious side effect. ARIA. Amyloid-related imaging abnormalities. This includes brain edema and microhemorrhages that can be life-threatening. This monitoring is non-negotiable. These MRI monitoring requirements, combined with regular cognitive assessments using validated instruments, provide the perfect medical explanation for reports. It explains why repeated neurological and cognitive testing would be occurring in private settings. The timing matches perfectly. Allow me to construct the unified clinical narrative this evidence supports. The subject presents with signs consistent with mixed vascular and Alzheimer's type dementia. The bruising on the dorsal hands, appearing repeatedly and being concealed, is consistent with biweekly or monthly IV infusion access. The reported cognitive assessments align precisely with the monitoring requirements mandated for anti-amyloid therapy. The behavioral and cognitive changes we observe are consistent with early to moderate stage disease, the exact population for whom these drugs are currently indicated. Additionally, it is worth noting that cerebrolysine, a neuropeptide preparation used extensively in Europe and Asia, is administered as daily IV infusions. The concealment with makeup is the behavior of someone who understands that visible IV bruising carries diagnostic implications they wish to hide. The side effects of anti-amyloid therapy deserve specific attention because they carry national security implications. ARIA, the brain swelling and microbleeding associated with these drugs, can present clinically with sudden confusion and severe headache. These events can be indistinguishable at onset from a stroke. The speed of the event is the danger. If an individual in the most consequential decision-making role on the planet is receiving these medications, the risk is not a medical abstraction. It is a governance emergency in waiting. A sudden mental status change or behavioral crisis could happen at any moment. The final episode brings everything together. We will synthesize the cardiovascular, neurological, sleep, and psychiatric evidence into a single coherent picture. We will offer a probable unified diagnosis, a prognosis, and a guide for the public on what signs to watch for that signal rapid deterioration. You now have the clinical vocabulary. Next episode, we use it. Join me for the conclusion of this investigation. For more stories and in-depth clinical analysis, visit unbedsidemanners.com. Insight through clinical reasoning.